I'm very pleased this evening to have with us Dr. Nissirios. He is a board certified cardiologist with the Valley Medical Group. He is located at 95 Route 17 South, Suite 105 in Paramus. That's 95 Route 17 South, Suite 105 in Paramus. And he's here tonight to talk to us about when to see a cardiologist. Thank you, doctor, for being here.
Thank you for having me. My name is Themistoklis Nissirios. I'm a non-invasive cardiologist. I have been in practice for the past 13 years, and I have just recently joined Valley for the past year and a half. A little bit of information for me. I was born at Valley, so coming back to Valley is like being back at home. So I have been asked to give a presentation in terms of when to see a cardiologist. And let me start this presentation for you guys. So the question is becoming when to see a cardiologist. So as the word implies, a cardiologist is a physician who specializes in the heart. So our job is to diagnose and treat heart conditions. Testing that would be cardiologist is able to perform and interpret is testing such as an electrocardiogram, echocardiograms, and stress tests. I'm going to be going a little bit more into details about them later on. And of course, at the end of the presentation, any questions that may come up about this testing, I'll be happy to answer. In addition to performing and interpreting this test, a cardiologist's job is to provide advice on preventative management and lifestyle modifications to help prevent cardiac conditions that may happen in the future. But if those cardiac conditions were to occur, then a cardiologist should be able to diagnose them and manage them accordingly, whether it is with further testing or with medical therapy. Now, what kind of symptoms usually a patient would have that would require a cardiologist's attention? Most of those symptoms will be mentioned to the primary care doctor, and the primary care doctor should be able to direct you towards a cardiologist. But most importantly, the symptoms such as chest pain or discomfort, any kind of discomfort, either most of the time people say on the left side, but it doesn't necessarily have to be on the left side. It can be in the center, it can be on the right side, it can be towards the abdominal area. All those discomforts, I mean, sometimes depending on your risk factors, they may need to be evaluated by a cardiologist. Symptoms of shortness of breath. Shortness of breath that happens with exertion. Shortness of breath that happens at rest. Shortness of breath that is periodic, that it's there all the time. The cardiologist should probably take a look at that as well. Symptoms of dizziness, or if you have a fainting episode, or near fainting episodes. In addition, symptoms of palpitations, of feeling an irregular heartbeat. When you notice any of those symptoms, that's when you tell your medical doctor or ask to be evaluated by a cardiologist. And lastly, symptoms of feeling your legs are swollen, especially down by the ankles. Those are symptoms that all of us above have to be evaluated and possibly treated by a cardiologist. Now, in addition to the symptoms, there are certain risk factors that a patient might have where a cardiologist evaluation will be warranted. So risk factors such as high blood pressure. Now, a cardiologist should be able to manage and diagnose reasons why the blood pressure is high and trying to provide the appropriate medical therapy. There's a whole laundry list of medications for high blood pressure, and usually a cardiologist is trained to find which medication is the most appropriate. High cholesterol levels. When your primary doctor usually does lab work, it should be done once a year. A cholesterol panel is usually checked. When certain numbers may be normal or considered normal, but for the cardiologist standpoint, we have high standards and we are more aggressive with management. So if there's a question about how to go after your cholesterol numbers, then the cardiologist should be involved as well. The risk factor is of diabetes. This is a very a high risk group of patients. Patients that have diabetes usually may present with atypical symptoms. So what we do recommend that if you're diabetic or even borderline diabetic, having a initial cardiovascular evaluation will make sense. Because we are equipped and trained to figure out whether we need to pay attention to more of your symptoms. And as I said, patients with usually do not present themselves with chest pain. They might have atypical symptoms that will need more further attention. In patients that you have family history of heart disease, depending on the age where their family history presents, then the degree of aggressiveness of therapy or evaluation has to be determined. And usually a cardiologist is the one that will make a decision. Do we need to do more testing? Do we need to address your cholesterol levels more aggressively? In addition, patients that have smoking or there is excessive alcohol intake, usually a cardiologist will be involved as well, because with those risk factors, then you have a higher occurrence of cardiovascular disease. And usually we are more aggressive in terms of looking after that. Finally, sedentary lifestyle and obesity, with those risk factors as well, we recommend being evaluated by cardiology, again, to kind of assess the whole risk and then make decisions in terms of what else needs to be done. Now, the question that we always get is when to seek care, but most importantly, emergency care. In those situations, if there's going to be a list of symptoms that I will describe, but when you have any of those symptoms, of course, you're going to need to get emergency care, especially in the emergency room, and then where they're going to actually call us to come and further evaluate it. So symptoms such as severe chest pain or chest pressure. If it is persistent, then we do ask you to go to the closest emergency room, because you can ask to see a cardiologist, but usually in our office, we're not able to address it accordingly. There's certain laboratory evaluation that needs to be done right away. And for the heart, again, time is money. Symptoms of sudden loss of consciousness. So there's a lot of reasons why somebody may faint. But if this is a first-time occurrence, and has not happened before, it has not been associated with lightheadedness or dizziness, this might be indication of something serious going on. So of course, first call is to your doctor or to 911 and then present to the closest emergency room. Now, we spoke about shortness of breath, but severe difficulty breathing and not able to walk around with significant shortness of breath, that also requires to seek emergency attention. There is a lot of reasons why somebody might feel short of breath, but it can be heart attack, it can be heart failure, it can be some kind of blood clots, but that's where you actually require to be seen in the emergency room. And then if cardiology evaluation is warranted, then will be called. Other symptoms such as sudden numbness or weakness, again, especially in one side, those might be suggestive of a stroke. So again, if this is something acute, you seek emergency care. And finally, some symptoms such as cold sweats, nausea, or vomiting, usually associated with chest discomfort. Again, we always recommend seeking emergency care, because most importantly, you have to be safe than sorry. Now, in terms of cardiology, what kind of tests and diagnostic procedures might cardiology do? And that's where I'm going to go a little bit more into detail. First test that we usually do and ask to be done is called it's an electrocardiogram. An electrocardiogram, it's basically telling us some information regarding the rhythm. It will tell us if it's a normal rhythm. It will tell us if there is an arrhythmia. It can give us some information regarding if there has been an old heart attack, but it's a screening test. So a lot of the times, its test might be read as abnormal. And to a cardiologist, we see those a lot. We see them every day. They might be normal to us. So if there is a question about an electrocardiogram, then there's more testing that may need to be done depending on the symptoms. Another test is called an echocardiogram. An echocardiogram is an ultrasound of the heart. With an ultrasound of the heart, you're able to check on the heart function. You are able to check on the valve function. And also you are able to check surrounding organs, and it can tell you a little bit more information regarding your pressures, and also gives us a lot of information. So that's will be another test that can be done and can be interpreted by cardiology. Another test is a stress test. When does a stress test usually happen? Again, if there is a question about symptoms, usually we recommend doing a stress test to assess and see if those symptoms are really related from the heart. In most patients, if you do a stress test and you're on the treadmill for 6, 7, 8 minutes and you don't have any symptoms and the cardiogram looks okay, the likelihood of having significant coronary problems or heart problems is very minimal. There are other kind of stress test modalities, especially in patients that are unable to walk on a treadmill. But again, the cardiologist, we do ask you to be evaluated first, so the cardiologist will make the determination of what kind of stress test to be performed. Another test is called an Holter or event monitoring. Usually this kind of testing is required or used for patients that complain for palpitations. We also use it in patients that have fainting episodes. We're essentially looking for irregular heart rhythms that can cause harm. The event monitoring usually lasts, a Holter monitor is only for about 24 hours, but usually we end up recommending an event monitor. An event monitor can last from 3 days to 7 days, up to 14 days. And of course, if we have significant symptoms or conditions such as history of stroke with no diagnosis, then a further monitored period may be required, but we can go more in details if we need to. Another test which has grown in our cardiology community is called the coronary calcium score. The coronary calcium score is a screening test that most cardiologists will recommend, and now probably your primary care doctors will recommend. It's a quick CAT scan that you go in and out from the CAT scan machine, and it's in the coronary arteries. We usually recommend it in patients that do have high cholesterol or they're diabetics, and they don't want to be, or they want to check what is the risk, so whether they need to be on cholesterol medication. By checking for a calcium score and having calcium in the arteries of the heart, that means that there is some plaque already forming in the arteries. I've used this test a lot in my patients that do have family history of heart disease. And by doing this test, I've actually caught a lot of patients, younger patients, that have developed some coronary artery disease. And what that tells me is that we need to be much more aggressive with our cholesterol management. And also with their symptoms. I mean, if you do a calcium score and you have a calcium score of 0, which essentially means nothing, then chest discomfort usually kind of be unlikely to be coming from the heart, from coronary artery disease. So that's a very good test. I have to say that a coronary calcium score, as I mentioned, is a screening test. Is usually not covered by insurance, but cost-wise, it ranges about $90 to $100. So it's a good amount of money that can be spent, and it gives us a lot of information. Now, other studies, of course, is that we perform as cardiologists. It usually is our colleagues, our interventional cardiologists, is a cardiac catheterization. A cardiac catheterization is a gold standard procedure where it kind of tells us for sure what is the degree of coronary artery disease. That's the test usually we do recommend in patients that have persistent symptoms. They have an abnormal stress test, or if they have another study is called a coronary CTA, which is like a non-invasive cardiac catheterization. So this is essentially the gold standard test, and then essentially it's an invasive procedure, but it actually helps with diagnosis and then treatment of coronary artery disease. Finally, we as cardiologists can interpret and also perform in our office vascular studies. Vascular studies such as carotid ultrasounds, abdominal aortic ultrasounds, and also lower extremity arterial ultrasounds. So those are usually, we're looking for patients that what we consider vasculopaths. And usually those are patients that have diabetes, or have a significant history of smoking. So those are tests that if you come to our office, will be, depending on your symptoms and also your risk factors, may be ordered and asked by the cardiologist to be performed. Now, if you were to be recommended to see a cardiologist, there's a few things that you need to prepare for and before you come in. One is you need to have all your be ready and have your symptoms. You can probably list them and come up in terms of what we do ask is in terms of the duration of symptoms. When did it start? Is there something that will bring on the symptoms, something that will make it better? All those informations, if you're kind of think about it ahead of time, of course, your cardiologist will ask those questions, but if you think about them, then it makes it much more easier, and our visit will be much more efficient. We ask you to bring a list of all your medications. Bringing all the medications, again, the names and the dosage will make sense. Sometimes, again, when you come in and bring and I've been told the white pill, the red pill, it's kind of difficult, but again, there's all those formularies. So it is important for us to know what you're taking. And so we can actually tell you possible side effects of the medication and also whether we need to make any kind of changes. Depending on your symptoms, be prepared that we might ask you to do more testing. And as I said, there have been occurrences in patients that have multiple risk factors that they may require more testing. So all the tests that we spoke about, those might be possible tests that you may need depending on all the risk factors. And most importantly, you have to be an advocate for yourself. What does that mean? Meaning that if you do have any symptoms or major risk factors, you want to ask questions and you want to learn and then ask for answers to your questions. Our job is to work with you and give us our expertise, and eventually we work as a team. But ultimately, we'll let you know what we recommend, and ultimately it's your decision to whether we proceed with doing further testing. Finally, the question becomes, why choose us? Why choose Valley for your general cardiology? And Valley Cardiology, and the Valley Medical Group, we have multiple cardiac subspecialties. What are cardiac subspecialties? There are cardiologists that actually do additional training, which include up to 3 to 4 years additional than cardiology. And those are such as what we call interventional cardiologists. Those are cardiologists that specialize in cardiac catheterizations and procedures such as stents or valve replacements. We also work in conjunction with our cardiac surgeons, and the cardiac surgeons work together with interventional cardiologists. We also have our electrophysiologists. Electrophysiologists are the electricians of the heart. They specialize in terms of irregular heart rhythms. So first, you will see, most likely will start with us with general cardiology, and then depending on their symptoms, risk factors, and the degree of aggressiveness that we need to do, we'll refer you to our cardiac subspecialties. In addition, Valley has built in a program with a second opinion from Cleveland Clinic. What does that mean? We're in direct access with Cleveland Clinic. So if there's any cases that we feel that we need additional help or guidance, we can confer with our colleagues in Cleveland Clinic. As I mentioned, with our Valley Cardiology, we're able, with all the studies and with our expertise, to catch heart disease in an early stages. And that's where, most importantly, prevention will come in. And I think having a good relationship with a cardiologist, depending on your risk factors in a younger age, then it makes much more sense. In addition, with our new hospital, we have our cardiologist service in one central location here in Paramus. And all our cardiologists, our non-invasive cardiologists, their visitor patients, and our cardiac subspecialties to provide the urgent care or more care that is needed. And lastly, all our cardiology department, especially in the cardiac subspecialties, we're at the forefront of cardiac research. What does that mean? Through cardiac research, we're able to test new testing modalities. We have access to newer medications or to new procedures that will help you with other cardiac conditions. So I think being in this location in northern New Jersey, you have access to the best of cardiac care possible, and we'll be very happy as a cardiologist to take care of you and your loved ones. Thank you very much for your attention, and I'll be taking any questions that you might have.
Sure. Thank you so much, Doctor. Just a couple of questions, actually.
Mhm.
One of the questions is how about a coronary calcium score. And someone had asked about how often, what is that, and how often should you have a coronary calcium score, CAT scan
So
done? Mhm.
So as I said, it's a quick CAT scan. It does not involve contrast. Depending on your risk factors, if you have a family history of early coronary artery disease, let's say your father had, or your mom or your siblings have coronary artery disease at the age of 40 or 50, we do recommend that you have it. I would recommend having it done soon. I'll give you my personal example. My father had a bypass in his 60s. I don't have really much of medical problems, but I checked my calcium score when I turned 40. I initially checked it. My calcium score was 1. I didn't do anything at that time. I repeated my calcium score 4 years later. And at that time, it did go up a little bit. So I've been on cholesterol medications ever since. Um, and the reason for that, again, we know that cholesterol medications are the only medications that's shown to prevent cardiovascular events. So answer to your question is depending on your risk factors, but I usually tell my patients 50 is the cutoff. That's where I usually recommend maybe checking a calcium score to kind of assess your risk.
Great. So somebody says, I'm in good physical health, has mild hypertension, it is controlled by olmesartan, has a good HDL, good calculated LDL,
Sure.
but a higher total cholesterol of 218. Would you recommend a statin? And what are the advantages and disadvantages of that?
Now, again, it all depends on the other risk factors, and we're looking for more. Again, I will probably ask you if you have a family history. There's a lot of risk factors. The way that I practice, I'm not as aggressive in terms of starting a medication because the reality is that I prefer not to give medication unless they're really necessary. And the reality is that most patients don't like to take medications unless it's really necessary. So that's where maybe a calcium score will come in, or maybe even doing a carotid ultrasound, because again, a carotid ultrasound is an ultrasound of the carotid arteries, which we feel is the window to our vascular world, is the closest artery to the skin. So if there's no plaque in the carotid arteries, there's no calcium in the arteries of the heart according to the calcium score, then you're making a good argument that there's probably not much of a benefit to be on cholesterol medication. Now, unless you have a very high cholesterol numbers, or there's more testing that we do. It's called advanced lipid testing, where we actually go more into the details about your lipids and to how high risk, what's the highest risk. But again, there's a lot of factors in there that help us make a decision on cholesterol management. But kind of testing such as the calcium score and the carotid ultrasound might help us a lot.
Great. Someone asked, does Valley have cardiologists who have additional training in treating cancer survivors who've undergone chemotherapy in the past,
Uh,
um,
so,
or on
so
continued oral medications? They were just asking for some names, but they were wondering about those cardiologists and those backgrounds.
all of our non-invasive cardiologists, what we do with our cancer patients, we work in conjunction with our hematologist oncologists, and in patients that have been on chemotherapy, of course, what is recommended is to have repeated echocardiograms. So with our studies that we do, which includes what is called strain echocardiography, we're able to communicate with the oncologist. So from the non-invasive standpoint, again, I don't know about whether somebody has specialized specifically on cardio oncology, but we do all work together with our oncologists, and we are well equipped to give you advice in terms of medications, in terms of repeat echocardiograms. So that's how we work on it.
Okay. Let's see. Does magnesium have to do a lot with the heart, and does it help? A lot of people are asking about magnesium.
That's a great question. Magnesium is one of the best supplements that somebody can take. I personally use it a lot, especially in patients that may come in with palpitations. Most of the time, people that complain of palpitations complain of heart flutter or heart skipping. And magnesium is a supplement that kind of quiets down the cell membranes and actually helps with palpitations medications. And also it has other benefits, such as it helps with muscle cramping, it helps with sleep. So that's a great supplement. So if anyone is having palpitations, even before they come to a cardiologist, advise them, take some magnesium. And then usually they might not need to come and see me. But magnesium, usually the formula that you may want to take is called magnesium glycinate. It has a better absorption comparing to the other forms. And usually we say about 250 to 500 milligrams per day.
Great. Yeah, a lot of people are asking about that.
Mhm.
So, in general, do you recommend as people just simply age? Because a lot of people are asking, like, should I just see a cardiologist regardless of my risk factors or just by virtue of getting older and having your heart checked?
Yeah, it always, I think one time, it all depends on your symptoms, but um, we are usually, again, as cardiologists, more equipped to go into great details. And I usually I like those questions. Again, when somebody comes to me and say, I don't really have any symptoms, but I want to make sure that
Mhm.
everything is okay. As I said, again, as a cardiologist, we are a little bit more aggressive. So what we do, if you were to come to me, and most cardiologists will probably do the same, is we'll take a closer look to your lipids. We'll try the closer look at your risk profile, and then make the appropriate recommendations. Now, the one argument according to the guidelines, as you get older, being over the age of 80 or 90, there's a lot of really much of benefit behind medications, and they might say, okay, you don't need to do much more. But our job here is, again, I don't look at the age. I mean, we see a lot of patients that are fine. They're at 80, 90 years old, and they're great, and our goal
Mhm.
is to continue. And a lot of those guidelines were done in older ages, so a lot of things have changed. And what I'm telling my patients is any kind of symptoms that you have, we need to check on them, regardless of what your age is. And I think a cardiologist will be easily to tweak in terms of minor symptoms and guide you appropriately, whether it's more medications or procedures that may need to be done.
Okay. Are there some basic guidelines that you would kind of suggest regarding numbers for someone would to start a statin, like somebody who has a calcium score for like 117? What would be your
So,
feeling, even if their blood pressure wasn't too high?
yeah.
Um,
So as again, if we spoke about what the calcium score
mhm.
is, but when you have the way that I look at a calcium score is a calcium score of 0 or non-zero. What does that mean? If the calcium score is the heart. Unfortunately, when your calcium score is abnormal, you have something that means that you already have developed some coronary artery disease. So you automatically have the diagnosis. The issue is not the number of calcium. The issue is what's surrounding that calcium itself. So it's not the calcium that might cause a problem, but it's surrounding the calcium. You might have what is called non-calcified plaque. And that's where cholesterol management comes in. Why is that? Non-calcified plaque is a plaque that actually might be prone of rupturing. And usually when you don't have the symptoms, when your blood pressure is good, you exercise, then non-calcified plaque might be the plaque that ruptures, and all of a sudden a blockage of 10, 20, 30% that might not cause any symptoms might automatically become an 80, 90%, and that leads to heart attacks. So I usually, again, I understand that might not be the answer that a lot of people look for, but I usually recommend if their calcium score is non-zero, if it's even it's 10 or if it's abnormal, I would recommend statin initiation. Um, so so again, I know we spoke about it. I think, as I said, my calcium score was checked when the second time was when it was 45. It had went up from 1 to 11, and I've been taking a cholesterol medication ever since because, again, I definitely want to prevent things from happening down the road.
Great. Now, I want to make sure I understand this. Somebody asked, does a statin increase LP parenthesis A?
Mhm.
Do you know
Well,
what that is?
that's a great
Or maybe
question.
just tell us what it is.
Yes. So lipoprotein A is a part of the cholesterol panel. It does it, it and that's in addition to when we check out a general lipid profile. profile, and that calculates your total cholesterol. It gives you information about your triglycerides. It gives you information about your bad cholesterol. It's called LDL. And it also gives you information about your good cholesterol, HDL. And lipoprotein A is usually an additional test. And it's a factor where if it's elevated, that is most likely genetically driven. That's one. And secondly, it gives us a little bit more higher risk of forming plaque. So if somebody has tested and has a high lipoprotein a statin or any medication that we have right now would not affect it. Unfortunately, at this time, there's no medications that goes after the lipoprotein A. That's not going to be the case in the next year or two. There's a few trials that are coming out that specifically look on lipoprotein A on medications that go after it. So at this time, what we tell our patients, if you were to find that you have a lipoprotein A, then you need to be much more aggressive with medical therapy. And once the new medications come out, although I don't like to prescribe them right away, I usually want to wait a little bit. Then at that time we have something to go after it as well.
Great. And I think that might let me just see one more. Oh, everyone, thank you so much. Oh, one more question, if okay, sorry, doctor.
Yeah,
Someone's
of
asked me
course.
the impact of chronic dehydration regarding heart health
So
or
chronic,
serum cholesterol testing. Is it reversible? I'm sorry, go ahead.
well, which one is the first one you want me to answer first?
What is the impact of chronic dehydration to heart health
Mhm.
and or serum cholesterol testing? Does that make sense?
So chronic dehydration, again, is mostly will present with symptoms, and symptoms such as lightheadedness, dizziness, and fainting episodes, right? So it is important to keep yourself very well hydrated, so to prevent and avoid those symptoms. In addition to that, what chronic dehydration might do, it might cause what we call electrolyte abnormalities, which may lead to palpitations. It might lead to irregular heart rhythms, and then some of those irregular heart rhythms can be dangerous. So again, so what is good practice is to hydrate yourself as much as you can. We usually recommend about 6 to 8 glasses of water a day. Especially that's for patients that don't have what we call heart failure, but I know most patients just hydrate yourself as much as you can. And then of course, keep up with your electrolytes, with your minerals and supplements, especially with the magnesium as we spoke about. Now, it's serum cholesterol, again, is the cholesterol lipid testing. And again, what you need to do is ask your primary to at least test them once a year. That should be adequate. And that will give you a little bit more information about your risk.
Great. And this will be the final question. And I think you alluded to this, but does statin affect a calcium score, like decrease it or just keep it the same? What would be your?
So that's another great question.
Mhm.
So what I tell my patients is, again, we use this calcium score as a screening test. So when you do the test, if it's non-zero, there's no reason possibly to repeat it again, especially if you were to start being on cholesterol medication. Why is that? If you have a calcium score that is non-zero, that means you already have formed some coronary artery disease. That doesn't go away. There's only one patient actually that I've seen that it actually went from a calcium score of 1 to a calcium score of 0. And that was in a patient that became totally plant-based, meaning stopped eating all animal products, and then it could totally reversed. But if there is abnormal, then the calcium score probably stays there, and as you get older, then it probably increases. Now, calcium score or calcium is considered to be what is called the protective mechanism of the body to plaque formation. So as you are taking a cholesterol medication, what does the cholesterol medication do? It's trying to stabilize the plaque that you have, and especially the non-calcified plaque. So that plaque eventually will become calcified, more stable, so it prevents it from rupturing. So that, guess what? If you were to do the calcium score, again, while on cholesterol medication, the calcium score will go up. So that's usually what I tell my patients. Again, I don't want them to say, once you make the diagnosis, after that, there's probably no need to repeat the calcium score again.
Okay, well, thank you so much. This was very interesting and great information. Thank you so much, Dr. Nissirios, for your time.